I'll introduce our next speaker now, Dr. Rachel Hart. Dr. Hart's a board-certified geriatrician with specialized training in memory care now with the Norton Neuroscience Institute's Memory Center. As a geriatrician, she has training in caring for older adults in multiple settings, but is now specializing in memory disorders. She's going to be presenting on what I think is a difficult but really fascinating and growing area in the field, understanding biomarkers. So with that, thank you, Dr. Hart, and I'll turn it over to you.
Thank you. And can you just let me know, does everything look good on your end where you can see the PowerPoint?
Yes, looks perfect.
Perfect. Thank you. Thanks for sticking around this morning. This is kind of a new topic to discuss on understanding biomarkers in Alzheimer's. But hopefully by the end of the presentation, we'll be able to determine when biomarkers are used in diagnosing Alzheimer's disease, be able to list the different types of biomarkers, and then also recognize their limitations. So first off, when are these biomarkers used? So a little background on the use of these is that the pathophysiologic process of Alzheimer's disease is thought to begin several years, maybe even decades, before we can make a clinical diagnosis of Alzheimer's dementia, meaning when they have clinical symptoms of dementia or functional impairment. So we have neuroimaging, mainly with MRIs, cerebral spinal fluid assays, and then other biomarkers that provide ability to detect the pathology of Alzheimer's. And this disease has a very long preclinical phase, which provides an opportunity for disease-modifying therapeutic interventions. And current lab work and clinical trial results suggest that the therapeutic interventions applied earlier in the course of Alzheimer's disease would be more likely to modify the disease. So hopefully in the future, trying to determine, can it be treated in a preclinical stage? Could we potentially prevent a full-blown clinical symptoms of dementia? So a little background on what we kind of think about as the neurodegeneration continuum. In 2011, the National Institute on Aging and Alzheimer's Association created a work group to form this hypothetical model of the dynamic biomarkers in a preclinical phase of dementia. So when we think about preclinical phase, we're really talking about patients who don't have any objective evidence of cognitive impairment. These patients tend to be, still independent, still functioning normally. But already starting in the preclinical phase, we start developing symptoms or signs in the brain of the pathology. So the first step is amyloid beta accumulation. An amyloid beta protein becomes misshapen, causing it to aggregate or clump into plaques. The brain is unable to clear these altered amyloid beta proteins, so they collect around the neurons and really start interfering with their function. This type of problem, or this accumulation of amyloid beta, is estimated to begin as early as 15 years prior to developing cognitive symptoms. Step 2 is what we think about with the synaptic dysfunction. The synapses are the spaces between two neurons, and they're really key in communication between those neurons. With the amyloid beta plaque accumulation, this communication at the synapse becomes impaired, and as more amyloid beta plaque accumulates, the cell signaling slows down more, and it leads to the progressive cognitive dysfunction. Step 3, we see tau-mediated neuronal injury. And tau is a protein that is normally found within neurons, and it has a role in stabilizing the microtubules. But with amyloid beta dysfunction, that then triggers these tau proteins to also become misshapen. And as the tau proteins misshape, they tend to bind to other tau proteins instead of the cell's microtubules. And these tau fibers then form the tangles within the neuron themselves. These tangles continue to accumulate until they prevent the communication between the neurons, and this primarily occurs in the brain regions involved with memory. And then step 4 is the change in brain structure that we see. So as the amyloid beta plaques and the neurofibrillary tangles accumulate, this leads to neuron cell death, and then leading to the atrophy or the shrinkage that we've seen previously on MRI imaging this presentation. And then this occurs specifically in the regions of the brain involved with memory. And then another way to just look at this, again, Alzheimer's disease is characterized by the accumulation of this amyloid beta and phosphorylated tau that leads to brain atrophy and cognitive decline. So really in the presynaptic or presymptomatic stage and in the mild cognitive impairment stages is where we're seeing a lot of these changes within the brain. By the time we get into the dementia, that's the dementia stage or the progression through dementia, that's where we're seeing the memory type symptoms. So also in this work group in 2011, they determined kind of a graphic representation of kind of a framework of staging in this preclinical phase. So stage 1 is considered asymptomatic amyloidosis. So the first time that we'll start seeing these individuals have markers of amyloid within the brain. Stage 2 is amyloidosis plus neurodegeneration. So we have evidence of amyloid, but we also have evidence of that synaptic dysfunction. And those could be measured with an FDG PET, a functional MRI, sometimes structural MRI, or total tau in our cerebral spinal fluid. And then stage 3 in this preclinical stage is really amyloidosis and neurodegeneration evidence, but also we start seeing subtle cognitive decline. These patients really do not yet meet criteria for mild cognitive impairment, and sometimes we'll think about these as those individuals who may report subjective memory impairment. I feel like my memory is worse, but we don't have any evidence of memory testing. And then after these stages in the preclinical phases, we'll then go on to mild cognitive impairment and Alzheimer's dementia. So according to the 2011 conference, these staging categories really were looking at were patients going to be having evidence of positive amyloidosis generated by amyloid beta protein measured in cerebral spinal fluid or PET imaging versus the stage 2 when we start seeing the neurodegeneration, and the stage 3 where we see the neurodegeneration and the subtle changes in cognition will also have positive markers for neuronal injury. Then in 2018, the National Institute on Aging and Alzheimer's Association work group had made some changes on how we look at biomarkers. So in 2018, the definitions changed where the presence of amyloid or amyloid beta biomarkers would determine whether or not an individual is in the Alzheimer's continuum, versus having tau, this pathological biomarker would determine if someone has Alzheimer's disease. And then they would use those as what they would call the core biomarkers, and then staging severity would really be determined by evidence of neurodegenerative disease or neurodegeneration with neuronal injury, and also the presence of cognitive symptoms. So the 2018, looking at these biomarker profiles, is where we first started seeing amyloid positive negative, tau positive negative, and neurodegenerative positive negative. All individuals who have negative amyloid, tau, and neurodegeneration signs are marked as normal Alzheimer's biomarkers, and Alzheimer's can be ruled out. On the other side of this table, those who are negative for amyloid but may have evidence of neurodegenerative disease or evidence of cognitive impairment, if they don't have the amyloid present, we can rule out an Alzheimer's and say that they have non-Alzheimer's disease pathologic change. And then in the middle, in the gray box, those who are amyloid positive, those are the biomarker positive for Alzheimer's. And then an important note, I think, to also think about as we're talking through these biomarkers, we're looking mainly at imaging studies with PET imaging or PET amyloid PET and cerebral spinal fluid biomarkers. And we kind of put them in the same group, but the main difference is that CSF biomarkers are going to be measures of the concentration of these proteins in the cerebral spinal fluid. They reflect measures of both production and clearance or their removal at any given point in time. So they're really more of a qualitative biomarker determining whether the amyloid's present or absent. Imaging measures, on the other hand, represent the magnitude of neuropathologic load or the damage accumulated over time. And then for an example, if we're thinking about cerebral spinal fluid and the amyloid beta 42 is low, it's a biomarker of a pathologic state that's associated with the amyloid plaque formation, but it's not necessarily a measure of how much amyloid plaque there'll be on an amyloid PET scan. Then in 2023, the National Institute on Aging and Alzheimer's Association made some updates to their recommendations on biomarkers again. And with these biomarkers or these recommendations, it really requires only the core biomarkers, the amyloid and tau, for the diagnosis and staging of Alzheimer's disease. So you can see kind of from the table they created, there are other biomarkers, including something like a biomarker for vascular brain injury, which really comes down to MRI imaging with white matter hyperintensities. And then there are biomarkers that are non-specific for Alzheimer's disease that we'll get into a little bit, but these that are going to be measuring more of the neuronal injury or dysfunction are not going to be something that would be used to rule out Alzheimer's or confirm a diagnosis. And then what are the different types of biomarkers that we have available? So mainly there'll be three types that we'll talk about. Those are the cerebral spinal fluid assays, amyloid PET scans, and then serum assays or blood-based biomarkers. So for cerebral spinal fluid, amyloid beta 42 is the biomarker that's related to amyloid beta in the spinal fluid. The level in CSF is negatively correlated with the amyloid plaques in brain tissue. So this means that the lower amyloid beta 42 in the CSF, it means the higher the number of amyloid plaques that we would expect to see on a PET scan. So positive biomarker in this case is going to be a low amyloid beta 42. Also, the ratio of amyloid beta 42 to amyloid beta 40 is associated with the risk progression from a pre-symptomatic MCI or from MCI to Alzheimer's disease. And then for the tau protein, there are measures of both total tau and phosphorylated tau, and these are associated more with Alzheimer's disease. So our specific phosphorylated tau biomarkers will be p-tau 181, p-tau 217, and p-tau 231. And then the total tau in the spinal fluid is a biomarker more for severity of neurodegeneration. So when we order a test that's looking at CSF biomarkers, this is typically kind of what we would expect to see. So there will always be reference values that will be listed on the right. Those will be for the beta amyloid 42, the total tau, the phosphorylated tau 181, and then a ratio of phosphorylated tau to amyloid beta 42. And I highlighted the 4 on this graph because this chart kind of highlights these are the combinations that we can have. So hopefully we're going to get this one, the 4th one down, that's the abnormal amyloid beta 42, phosphorylated tau, and total concentrations. All 3 are abnormal and present in the CSF, and this is the one that is primarily consistent with the presence of Alzheimer's disease. There can be some variability, meaning that we can also have an amyloid beta 42 that's abnormal, a phosphorylated tau that's abnormal, but the total tau could be normal. These results are also consistent with Alzheimer's disease. And then there are 2 other combinations that may be consistent with Alzheimer's related pathologic change. And this comes down to kind of looking at some of our other studies that we may have done for these patients. Maybe they've also had neuroimaging done. Maybe they've had neuropsychology testing done. Maybe they have other medical comorbidities that have been evaluated that we need to consider with these as well. But for these that are maybe consistent with Alzheimer's related change are those who have only an amyloid beta 42 that's positive, or those who have an amyloid beta 42 that's abnormal and a total tau that's normal. So the limitations of cerebral spinal fluid biomarkers, there are several. Working in our healthcare system like Norton, these are readily available, but we also have the availability of specially trained neuroradiologists and interventional radiologists who can do this. But from a patient side, they're also highly invasive and they do have more of a physical burden on an examinee. So our second biomarker is our amyloid PET scan. And amyloid PET imaging requires agents that bind to an insoluble amyloid beta plaque, and these can appear years again before the onset of clinical symptoms. In clinical settings, the amyloid PET scans are visually assessed by nuclear medicine physicians, and they're marked as either positive or negative based on the presence of amyloid PET signal in the cortical regions, and this will be measured in a unit called centiloids. So kind of, again, just thinking about how, what are the two things that we're looking at, our amyloid and tau proteins. When we look at a PET scan, we're going to be looking at considering an amyloid PET that's negative versus an amyloid PET that's positive. So the positive PET scan on the right, you'll notice what is called the hotter colors, the more reds, yellows, and oranges. And these hotter colors are more amyloid PET tracer binding, versus the amyloid PET scan on the left has what we would call colder colors or more blues. And this indicates that there's a low amyloid PET tracer binding. So the prototypical amyloid positive PET, or what pattern we're looking for that's most consistent with Alzheimer's disease, is where the amyloid is elevated in the brain's posterior cingulate cortex, the prefrontal cortex, and the lateral parietal and temporal cortices. These regions also display minimal tracer uptake in the amyloid negative case on the left that has a low binding for the whole cortex. The other thing to note on this is that for those patients who also have white matter changes, those white matter hyperintensities or small vessel ischemic disease, there is some low level of binding to from the amyloid PET tracers to that white matter. So the patient who's on the left, even though it's amyloid negative, there is a little bit of yellow or a little bit of binding, and that's likely because they have white matter disease as well. So the limitations of an amyloid PET primarily are the expense. So there's a question earlier on coverage for some of these tests. In 2023, Medicare changed their guidelines for covering amyloid PET scans if they were used for the diagnosis or monitoring for Alzheimer's disease, but we have not yet seen that play out in a clinical setting, how that's paid for. Medicare changes their guidelines, but the cost for any kind of testing is actually based on local Medicare administrative contractors, or MACs, and that local coverage determines the decisions that are based on the MAC. So if we look at what the cost of an amyloid scan might be in Kentucky, it could be different if we were looking at Boston or California, and the coverage of that test is really determined by these MACs. On average, a PET scan can still cost $5,000 to $7,000 to complete. So if there's not coverage by Medicare, this is not I think, feasible test for biomarkers for most of our patients. And then the other thing with PET scans is that there are several types. I know we've mentioned an FDG PET a couple of times. Those are not specific for Alzheimer's disease. They could mark a level of neurodegeneration for a patient, but they can't confirm an amyloid positivity. And there's also tau PETs that are primarily used in a research center. They're not used in a clinical setting, but this also can indicate if someone has a tau status that's positive. So if we're looking at all of the biomarkers that can be checked with maybe CSF studies, if we were looking at trying to get the same information from a PET scan, we would have to get more than one PET scan. And then our third type is our serum or our blood-based biomarkers. And there are quite a number of these, and they all have different levels of sensitivity or specificity. So in the two corners on the top, the amyloid beta pathology, again, are going to be the beta 42 and amyloid beta 42-40 ratio. Those are going to be specific for our amyloid beta pathology. And then tau pathology biomarkers are going to be our phosphorylated tau 181, p-tau 217, and p-tau 231. There are also two phosphorylated taus, the N-terminal p-tau and mid-region p-tau. So the amyloid beta pathology and tau pathology are really most specific for Alzheimer's disease. There are also other biomarkers that may be more indicative of just general neurodegeneration. So for instance, a neurofilament light could be positive in Alzheimer's, but it's also a marker of neurodegeneration. So it could be positive in other diseases like multiple sclerosis or frontotemporal dementia. The same with t-tau. Total tau in the brain is not specific just for Alzheimer's disease, but it could mark the level of neurodegeneration in spinal fluid. And then there are also markers of neuroinflammation, and these are really more from a study or research side. They're not used in a clinical setting, again, because they're not very specific for Alzheimer's disease. So our blood-based biomarkers, the amyloid beta 42/40 ratio is measured by high precision assay, and it can arguably detect whether the amyloid is abnormal even before an amyloid PET reaches the threshold of positivity. And p-tau 217 is probably the most common blood-based biomarker that's elevated in the presence of amyloid plaques. It correlates with tau tangles in Alzheimer's, but it does not correlate in our non-Alzheimer's disease pathologies that are related to tau. So when we do blood-based biomarkers, what we're trying to get with our amyloid beta 42/40 ratio is to try to create an amyloid probability score. So would an amyloid positive or an amyloid probability score predict a positive or negative amyloid PET scan? So a low APS is consistent with a negative amyloid scan and would be considered inconsistent with an Alzheimer's disease. And then a high APS score is consistent with positive amyloid PET and would be consistent with Alzheimer's. Where this can become a little bit tricky is if someone were to have an intermediate APS score, because that cannot distinguish between the presence or absence of amyloid, whether it would be positive on a PET scan or not. And then I did want to mention a couple other biomarkers that I'm not going to spend a lot of time talking about, but I think are important to think about. So CSF and PET amyloid imaging are again estimates of the deposition of the fibrillary forms of amyloid beta. So these are primarily what we're going to use, but there are also functional MRIs and FDG PETs that can measure synaptic dysfunction. Also, if we think about CSF, total tau and volumetric MRI scans, they can be markers of neurodegeneration, but they're not going to be specific to an Alzheimer's process. And then the limitations of our blood-based biomarkers, in many ways, a lot of these are not yet FDA approved. And so that would require someone like in our office, when we use them, we have to have some kind of partnership with a commercial company where we have the ability to do these tests. And that may vary based on where someone is practicing in a clinical setting, what blood-based biomarkers they would have available. Also, many of the biomarkers available in our CSF are present in plasma, but they're in much lower concentrations. So the immunoassays really have to be pretty ultra-sensitive. The robustness of a plasma 42/40 ratio quickly reduces if we increase any kind of interassay variability, and increasing a coefficient of only 5% impacts whether a PET scan would be considered positive versus negative. So a lot of work has to be done in biomarkers to make them sensitive enough to pick up the beta 42/40 ratio. And then last of all, just recognizing the limitations and how we use biomarkers is also important. So biomarkers in clinical use, it's important to think about when these were created. Biomarkers were originally constructed for a research framework for developing the definition and diagnosis of Alzheimer's. The framework was worked to establish a clinical biological diagnosis of Alzheimer's disease. But in 2018, when the National Institute of Aging and Alzheimer's Association work group met, they proposed to have a purely biological definition of Alzheimer's, both for asymptomatic patients who did not yet have clinical memory symptoms or decline versus those who were symptomatic with clinical symptoms of dementia. So according to the 2018 definition, this would mean that even in the absence of cognitive symptoms, the presence of an abnormal amyloid and tau biomarker would be defined as Alzheimer's disease. And this is something that's still controversial. So the limitations of kind of thinking about a purely biological definition of Alzheimer's disease is really that I don't think from a clinical side, we're not yet there where we can think of Alzheimer's disease as just biological. There have been several studies that have indicated the presence that both amyloid and tau positivity could be insufficient in predicting whether the occurrence of symptoms, whether a patient would develop mild cognitive impairment or dementia. If they're positive, these markers are positive when these individuals do not have cognitive impairment. So when we think about them being cognitively normal, they may or may not actually go on to develop mild cognitive impairment or dementia. Some studies have quoted as high as 25% of cognitively normal individuals over the age of 65 can still have positive biomarker studies. Also, some of these studies have shown that follow-up of these cognitively unimpaired biomarker positive individuals does suggest that the majority of these individuals do not progress down the continuum of dementia over time. These biomarkers also don't account for co-pathologies. As Dr. Dennis mentioned in our first presentation, what we're learning more, especially through things like autopsy studies, is that at least 50% of what we consider Alzheimer's dementia are estimated to be attributed to co-pathologies. So maybe these patients have mixed Alzheimer's and vascular dementia, maybe they have mixed Alzheimer's and Parkinson's dementia. But the biomarkers that we have are currently available for Alzheimer's, but we don't have biomarkers currently available for the pathological changes that are the non-Alzheimer's neurodegenerative disease. And then there are also biomarker thresholds. So depending on where the biomarker assay was developed, the location, the site, or the study, there has to be a clear-cut separation between positive versus negative for patients. And that positive versus negative separation can vary based on a site or a study. And then amyloid PET restricts amyloid deposition to being either intermediate or high, but different amyloid PET tracers exist, and that means that there's going to be variability in these measurements. So where one amyloid PET tracer may be marked as an intermediate, if it's used on another scan or another study, it may be marked as a high. And then the last thing is that having a diagnosis of Alzheimer's disease just based on positive biomarkers does risk creating diagnostic confusion as well, especially for those patients who are cognitively normal. Would they be considered to have a dementia illness? Would they need to start thinking about things like, needing to stop driving right away or moving into an assisted living? Sometimes individuals will make decisions, I think, preemptively and probably take away some of their independence even before it's needed, and that can change the clinical course of how their illness may appear. And so kind of from a summary of that is that really biomarkers from a clinical setting should only be used as diagnostic testing for those who are cognitively impaired. And that needs to be based on objective cognitive testing. So just because someone who's 50 years old says that I'm concerned that I could develop dementia because my mom or my dad developed it, is there a way to check to see if I have Alzheimer's or if I'm going to get it? This is not when we should be doing biomarker testing. This is really for an individual who comes in, reported symptoms of memory impairment, cognitive testing is done, there's objective evidence of cognitive impairment. Then we would do biomarkers, either one to help establish a diagnosis, which is primarily the reason to rule in or rule out Alzheimer's disease. But they're also used in the setting of determining eligibility for our new therapies, our new anti-amyloid monoclonal antibodies. So a couple things that I wanted to just go through, kind of some case examples of when we might use these biomarkers. So the first gentleman is a 75-year-old man presenting with progressive short-term memory loss. He's been repeating conversations for the last year. He's missed a couple of his grandchildren's sporting events due to difficulty keeping up with dates. And he's recently missed paying some of his monthly bills on time and had to pay late fees. He's a caregiver for his wife who has moderate stage dementia. Their niece is a nurse at the VA and had heard about a new medication, lecanemab, and his family wanted to see if he would be eligible for it. So his MoCA is a 21, so some mild impairment. His MRI showed that he had some mild diffuse cerebral atrophy and minimal microangiopathy. So while that cerebral atrophy was pretty diffuse, meaning across the brain, it could indicate he has a neurodegenerative disease, but it would not be specific for Alzheimer's. And since lecanemab is an anti-amyloid monoclonal antibody, this individual has to have amyloid present to be eligible for the medication, or it will not be successful for them. So he underwent CSF biomarkers. His phosphorylated tau amyloid beta 42 ratio was high. His amyloid beta 42 was low, and his phosphorylated tau 181 was high. So he had positive biomarkers for Alzheimer's disease, and we could diagnose him with an early stage of Alzheimer's. The CSF biomarkers were chosen for this gentleman mainly because he was being assessed for eligibility for lecanemab. And currently our anti-amyloid monoclonal antibodies, we have to have the presence of amyloid, but that requires either doing CSF studies or an amyloid PET. And those are the two that are chosen mainly for insurance authorization. And then our second clinical case is a 74-year-old woman. She's had progressive short-term memory loss, misplacing items for the last few years. This includes things like losing her Medicare card several times. She's forgotten to pick up some of her prescription medications on time. So she's started to miss many of the days or the frequencies of when she needs to take those medicines. So her husband's been taking that over in the last year. She's had 3 maternal aunts who have been diagnosed with dementia, and she's been worried that she's developing Alzheimer's disease. She has a history of relapsing remitting multiple sclerosis and was diagnosed 46 years ago. She has not been on disease-modifying therapies for MS. She is an individual who is not against taking medications, but does want to minimize prescription medicines and really feels like I only want to take these if I have no other option. But she was worried about Alzheimer's and wanted to know, should she be on treatment, and if so, what her options might be. Her MoCA is also a 21, but her MRI really didn't show evidence that we would be suspecting of a neurodegenerative disease like dementia, mainly because she really didn't have any kind of specific atrophy patterns. But what it did show was that she had pretty extensive hyperintensities and sclerosis changes corresponding to chronic multiple sclerosis. She didn't have any active acute demyelination, but she did have scarring from the chronic MS. So she elected to complete a blood-based biomarker test, and her amyloid probability score, her APS, was very low at 7, which was consistent with the absence of brain amyloid plaques. And then her other 2 markers, the phosphorylated tau 217 ratio and her beta 4240 were also normal. So all 3 of her markers were low, and her amyloid probability score, or the likelihood of her having a positive amyloid PET scan, was very low, meaning that her biomarkers were negative. So for her case, she really chose to do biomarkers because she wanted to determine, would it be of any benefit for me to be on a medication for Alzheimer's? If I don't have evidence of Alzheimer's, I don't want to take any sort of medication. But she's also not going to be a candidate for our anti-amyloid medications, mainly because of the extensive changes that her MS has created in her scans in her brain. And then the last page that I included here, in case anyone is interested, are some references, and then I'm happy to take any questions.
All right, thank you, Dr. Hart. That was really terrific. That last, I'll ask a couple, and then we've got some here in the queue. The last one you mentioned, using a blood-based biomarker essentially to rule out Alzheimer's disease, I think was really very illustrative. Can you go through a little bit of the thought process for choosing why PET versus CSF versus blood-based biomarkers, and then as a add-on to that, a little bit about the coverage. In this case, you did a blood-based biomarker.
Yeah.
Tell us a little bit about the coverage for that.
Yeah, so I will say one of the things that patients really like about blood-based biomarkers are that it's easier to do. They don't have to worry about another appointment. They don't have to worry about having a lumbar puncture. But at least the ones that we have had experience with is that they are not, while they're very accurate and they have they're very sensitive compared to an amyloid PET scan, they're not FDA approved yet, so that means they're not covered by insurance. The company we work with does have a financial assistance program, so patients can complete some financial forms beforehand to determine based on their average monthly income, will they have a decreased cost of a blood-based biomarker. So for the company that we use, the lowest that it would cost a patient out of pocket would be $250 versus someone who does not have any need from a financial side is going to be $1,400. So the cost of that blood test, I think for a lot of our patients is really the primary reason why we would or would not do that. I also look at, the reason of why we're doing the biomarker testing, what's our outcome going to be? So if I have a patient, like the second one, she would not be a candidate, even if she had Alzheimer's disease, we would not be really thinking about her as a potential lecanemab or monoclonal antibody patient. Would there be a benefit for her to have CSF biomarkers? Probably not. So if it's something that's affordable for her and something that we can complete and give her the adequate information, we don't need to worry about an amyloid PET scan or a CSF. I honestly have not had a clinical indication where I could say I would prefer an amyloid PET over a CSF biomarker, and mainly it's because, again, thinking about the outcome. So a lot of the patients that we've had that have wanted to complete biomarker testing are looking at their eligibility for those monoclonal antibodies. And if we are already looking at a medication that the basic cost is $26,000 a year, now hopefully that's covered by their insurance at max amount or a large amount. We're still thinking about a test that could cost $5,000 to $7,000. On top of that, if it doesn't have coverage, it just logistically doesn't make sense for a lot of people.
I agree. It's a lot of money.
Mm-hmm.
So, you answered this. Actually, I think it was well spelled out in one of the slides, but it's worth going over again. One of the questions is, how do we test for these various biomarkers? And I think they were going back to the slide you showed of the sort of cascade of synaptic dysfunction, of beta amyloid, of tau. Can you just say very briefly, again, a high level summary of what tests we use for different biomarkers?
Yeah, I would think the main thing about Alzheimer's biomarkers is really going to be thinking about amyloid beta pathology and phosphorylated tau. Those are the two that are going to be specific for Alzheimer's. The others that are evidence of neurodegeneration, like yes, a functional MRI or structural MRI are important, but the findings on those are not going to be specific for an Alzheimer's pathology. A couple of the slides that the NIA, the National Institute on Aging and Alzheimer's Association work groups created, kind of the other two biomarkers we would think about for those patients who have like Parkinson's or Lewy body disease. Those are called alpha-synucleinopathy disorders. There's a whole separate biomarker that can be done for those patients, but it has nothing to do with Alzheimer's pathology.
And maybe just one last thing, I re-emphasizing a point that you made, that in terms of the indications, when would we do biomarker testing? I have now had, and we will probably all have, folks that come in without objective evidence for cognitive impairment, but now they have positive biomarkers, and trying to parse out now, is there a difference between Alzheimer's disease and Alzheimer's dementia, is very, very difficult for me. Would you mind saying just a bit more about that?
Yeah, I think I would agree. And I think this is where biomarkers can be confusing if we look at a research setting versus a clinical setting. I think the idea behind why we're looking at biomarkers and why so much is being done to develop them more fully is that hopefully we'll have a biomarker someday that could show evidence of this patient is definitely going to have Alzheimer's disease and they're going to progress to an Alzheimer's dementia, that clinical and functional impairment. But right now, I just don't think that we can say that for cognitively normal patients. If they have these normal biomarkers, there are a lot of patients, or these abnormal biomarkers, they may be cognitively normal, biomarker positive, but still not go on to develop a dementia. And that creates some problems with patients because, I mean, I know I've had patients that have done some kind of genetic testing and said, oh, I have 2 copies of ApoE4, I'm definitely getting Alzheimer's, which is not true. But they've already changed their life and they've moved into an assisted living sooner. They've given up driving. They've given up a lot of their protective, I think, clinical things that help with their progression through a dementia. And so we really, I think, also do a disservice to some patients because we change what their outcomes may be.
I think we have very similar views on this, and these are potentially very powerful tools, but should be used carefully.
Right. So I think the main thing is that patients need to be cognitively impaired. There needs to be objective evidence of cognitive impairment.
Yes, that's an important point.
Yeah.
All right. Well, thank you very much. It was a terrific talk.